see the P wave. We can think of this as lighting the fuse of a firecracker. This is a representation of the atrial contraction. This is the QRS complex. This represents ventricular contraction, and so we can think of this as the Big Bang, followed by ventricular repolarization, or the T wave. We can think of this as the reset. So remember, atrial excitation or contraction of the atrium happens when the P wave comes. Next, the QRS complex is ventricular contraction. And then we have the T wave, which is the resting phase or the reset. So here we see a rhythm strip with sinus rhythm. And we can see that each P wave is uniform and regular. And a P wave comes before each one of the QRS complex. And each QRS complex has a T wave at the end. And the T waves are also uniform. So we can establish a heart rate from a 6-second strip. And if we count the QRS complexes in this strip, we will note that there are 7. And if we multiply that by 10, we have a heart rate of 70. So you can have an EKG tracing done while you're laying in a bed at rest with the electrodes placed and a tracing. We can also do something referred to as a Holter monitor. And this is a continuous tape recording of a patient's EKG for 24 hours. So it's worn during regular daily activities. So we want to make sure that the patient wears a button-down shirt so we can apply the electrodes. We want the chest to be cleansed with alcohol solution to ensure the attachment of the EKG electrodes and that they stay on for a 24-hour period. And we may even have to shave some small areas. And so we put these circular white patches or electrodes on, and then thin wires are used to connect the electrodes to a small event recorder. And the client keeps a log of their daily activities. So remember, a perfusing rhythm requires synchrony. So if each separate cardiac muscle cell can repeatedly contract or beat by itself at its own pace, we call this fibrillation. So when the cells beat separately and on their own, this is referred to as fibrillation. When the ventricles, which are the main pumps, are fibrillating, there can be no heartbeat. So ventricular fibrillation, a tracing of that would look like this. And this means that the heart is not pumping. So this is very bad and requires chest compressions, oxygen, a call for help, the crash cart, shock, and advanced cardiac life support. Okay, because this patient has no pulse. So do not confuse ventricular fibrillation with atrial fibrillation. Atrial fibrillation is depicted here. And what's happening is that the atrium are not contracting in a uniform fashion. We see that there are not P waves that are occurring uniformly before each QRS complex. So atrial fibrillation is a major cause of strokes. It's a major reason to give Coumadin. We don't want to convert the atrial fibrillation to sinus rhythm until we know there's no thrombus. So atrial fibrillation can be stable or it can be unstable, in which case our patient may be feeling short of breath and may become a little tachycardic. Then they're no longer in a stable atrial fib. So we want to shock this if it's unstable. And if it's stable, we want to obtain an echocardiogram to rule out atrial thrombosis. The way we do this is via transesophageal echocardiogram because it has the best view of the atria. So here we see a depiction of atrial fibrillation, and so these little clots can form inside the heart here, and so we don't want these clots to get pumped out into the bloodstream, cause some blockage. Here's a picture of what a transesophageal echocardiogram looks like. There's actually a transducer that is inserted through the mouth into the esophagus, and we get a real close up there of the atrium. So direct view of the atrium, and we can detect clots in the atrium. We're going to treat the clots with a medication called Coumadin. So the patient needs to be NPO for 6 hours to minimize the risk of vomiting and aspiration during the procedure, except that medications may be administered with sips of water if you're not instructed to hold the patient's medications. So before transesophageal echocardiogram, we want to know if the patient has any drug allergies, any difficulty swallowing, or any problems with the mouth, esophagus, or stomach. During, we want to monitor their sedation level. We want to check their vital signs, make sure their O2 saturation is good, that we may need to do some suctioning, and give the patient some emotional support. After, they may have a sore throat, and we can advise them that this should subside over time. We want to monitor their sedation level again, vital signs, and oxygen saturation. So an echocardiogram uses sound waves to produce images of the heart. And so just a standard echocardiogram can be used to identify various abnormalities in the heart muscle or the valves. So this can indicate how well the heart is beating and pumping blood. Here we have a video. So a standard, non-invasive echocardiogram, the gel is spread on the chest wall and the transducer is pressed against the skin, aiming the ultrasound beam through the chest to the heart. And so we're recording these sound waves and echoes produced by the heart, and the computer can convert these echoes into moving images on a monitor.